Testing. Good morning, everybody. I'm Mackie Moore, and I am one of the Wheelies, which is the board of the Silence is Not an Option group, which I just want to make sure everyone knows is not just for women. And if you look around today, you will see that that is true. We wanted to encourage women to have a voice, but in our mission, we said women and all allies. And so if you love women, we love you. So just want to make sure y'all know that. I want to welcome everybody and thank you so much for coming out on your Saturday morning. I know that that's a little bit of an effort, and we're very grateful to you. And we're really trying hard to bring good speakers, people that can help us navigate all the policy right now and all of the effects that this new administration's policy is having on all of the issues that we care about. So we're going to continue doing that. And I just want to give this announcement. This is a first, hot off the press. On December 3rd, from 6 to 7:30, David Beasley is going to be speaking here. So, David Beasley was the governor of South Carolina. And even before he was the governor of South Carolina, at age 20, he was in the House of Representatives. He was already working in his early life for the state. And yes, he is a little more conservative than some people here, but we want to embrace anyone who is just not on either extreme and angry. We're trying to be civil, we're trying to create discussion, we're trying to educate ourselves as well as y'all, and that's why we're doing these presentations, is so that when we go and vote, we actually understand the issues better. So I hope that this is helping y'all as much as it's helping me, because I've learned so much already and just look forward to all that's to come. I want to acknowledge and say thank you for coming to the College of Charleston Students in Global Health. We are trying to infuse SINO with some young people, so if y'all wouldn't mind standing up real quick, I just want to thank you so much for coming. I'm not trying to embarrass you, but really appreciate it. And please bring all your friends and everyone here. Bring your kids, bring your grandkids. We'll start early. We'll start educating now so that we don't have to go through this again. All right, now for a little business. We have a link for a live stream of every speaker that we have. And all you have to do, it's really basic, is Google Circular Church YouTube. That's all you have to do. It'll pop up, you click on it, and then if you want to watch the live, as in if you were home right now and wanted to just watch, then you click the live. And if you want to watch the recording later, just click recording, and then you'll see it listed in there. We had a little labeling incident with our last video about the Constitution. So if y'all want to see that, you can see the recording, and it no longer has the wrong title on it. It now says Citizen's Guide to the Constitution. So just wanted to make sure y'all knew that. So the live stream and recording thing is much easier than it looks or sounds. It's just Circular Church YouTube. Now for today, one other thing is, if you're a member or if you're joining us, we would love for you to stay after for just a few minutes so that we can give you a little update. It'll be quick on what we did at our board retreat, so that we can discuss what we want to do moving forward. And we really want to hear from y'all. So if you have ideas about somebody you would like to hear, an issue you would like addressed, please let us know. And if you have any other ideas, we've got all kind of neat things coming up. We're going to do a book club, book study, and we're going to divide into groups and study the book on tyranny. So if anybody wants to get started reading that, there's a short version. I'm not talking about the big version, but there's a short version, and then we're going to have facilitators to lead these book groups. And it's an incredible book. It's actually the first book I was told I had to read when I was going for a major in government. So that's really neat. I'm excited about that. Thank you, Jane Aiken. And I want to introduce now one of the SINO, silence is not an option, wheelies. Jan Anderson is going to introduce our special guest today. Jan is a Charleston local. She's a graduate of Duke University. She is an Isle of Palms Town Council member. She's very active in the community. She works a lot with the YWCA and is now become our chair of our event series. So she is actually coordinating the events every month and getting it together for us. So Jan Anderson, thank you.
Thank you, and thank you all for coming today. We have an exciting program that I'm particularly interested in on health and science research. We have two distinguished professors from MUSC that will give the presentation. And for me, it's really important because in this day and age, I'm a polio survivor. So if you talk about health research and what it does, I was born before there was a vaccine. So I really do want to hear what they have to say. The first is Dr. Kathleen Brady. She's a distinguished professor and director of the South Carolina Clinical and Translational Research Institute at MUSC. Dr. Brady is a psychiatrist and a pharmacologist, so I guess that's what that means, conducting research in the fields of addictions and psychiatric disorders. Throughout her career, she won numerous research grants, published more than 400 articles, and edited and co-edited a dozen books. She served on the MUSC faculty for the past 40 years, rising to the position of Vice President for Research. Among her many awards, she was named one of the best doctors in America 20 times and one of Charleston's most influential people by the Charleston Magazine. She received the South Carolina Governor's Award for Excellence in Science, the South Carolina Women of Achievement Award, and the Betty Ford Award for contributions to science. Dr. Brady served as president of the Association for Medical Education and Research in Substance Use Disorders, the American Academy of Addiction Psychiatry, and president of the International Society of Addiction Medicine. And she will lead our discussion on what's happened with health and researchers on our discussion today. With her is Dr. Jane Joseph, who earned her PhD in psychology from UVA and conducted postdoctoral research at Georgetown University, where she investigated, let me see if I get this right, neurosubstrates for rapid naming in the study of developmental dyslexia. So it's really how minds work. After a decade at the University of Kentucky, she joined MUSC Department of Neurosciences as a professor and a researcher. Her lab is funded by the National Science Foundation, I hope so anyway, the National Institutes of Health, and Autism Speaks. She serves on the editorial board of the Journal of Neuroscience Methods, and she reviews grant applications for NSF and NIH. So I'd like to welcome Drs. Brady and Joseph today, who will discuss the impacts of our current U.S. policy on health and science research. Dr. Brady.
Thank you all for being here. And thank you all for caring about this topic, which is, I think it is incredibly important. Now, I just want to make sure, how are we doing on the sites? We've been having an audio-visual crisis for about 45 minutes now, and I think they're going to show up on either side, correct? It's part of our theme. Okay. Oh, really? Okay. All righty, that's great. Now we just need to put them in presentation mode, right? Should I do that or you? Okay, I got it. Gotcha. Okay. So today, Jane and I are going to be speaking, we're going to give you an update on health and research pretty much since January of this year. And I think between us, we have two important disclaimers. One is, wait a second, I got to go back to this. Okay. One is that while we're both faculty at the Medical University of South Carolina, nothing that we say reflects the Medical University's opinion. This is just our opinion. But it's actually more than our opinion. It's really factually based. So, and the second disclaimer is that everything we're going to present today, it's horrible, it's terrifying, but this is a true story. And we have not withheld names to protect the innocent, because as far as I can tell, the only innocent victims here is the American public, and in particularly vulnerable and impoverished people. So that being said, I think we're going to be pretty clean with fact checkers, because we really have used all kinds of very valid resources in terms of the information that we'll present today. So let me just give you an overview. I'm going to talk about healthcare and then very briefly on health policy, mostly talking about vaccines and what's going on at the CDC. And then Jane's going to take over and talk about research and what's going on in that area. This is a complicated diagram. I don't expect anybody to really digest it completely. I just want you to note that the Secretary of Health and Human Services answers directly to the President. It's a cabinet office. Underneath that, behind a couple of layers of administration, are the Center for Disease Control, which we'll talk about today, the Centers for Medicaid and Medicare, and then a number of different assorted offices that take care of things like mental health care, substance use treatment, preventative services for the citizens of the United States. Basically, HHS's mission is that it is responsible for protecting the health of Americans and providing essential human services. That's what they have on the website. And so, as I said, all of these public service agencies, you guys have all heard of them, fall under HHS. And we're going to talk about Center for Disease Control, HRSA, SAMHSA, and then certainly Medicaid, Medicare. Jane will be talking about NIH mostly. So just to begin, our Secretary of Health and Human Services is RFK, who was confirmed by the Senate in February. He was sort of a controversial pick, mostly because of his lack of medical expertise. He's a lawyer who's done a lot of prosecution of vaccine, he's a anti-vaxxer. He has really no public health expertise and no experience in running a large federal agency. His public reputation is one as a prominent vaccine skeptic. He has embraced anti-science conspiracy theories. But his opening statement in that confirmation hearing was, "I am not anti-vaccine." So our other leader, who I think is just important in this, is Dr. Oz, who oversees the federal health care programs. He oversees Medicaid, he oversees Medicare, he oversees the Child Health Agency and the Affordable Care Act. He is responsible for setting policy and regulatory direction for the United States. Between these agencies, they provide health care coverage for 50% of Americans. And there were concerns with his appointment as well. He has no experience in the federal government, and he has no experience in health care policy or health care finance, which are really complicated areas, to be honest. So, and I just have to say this, leadership matters. And it does feel like we're being led off a cliff. So, just a timeline of the major changes. Remember, RFK was appointed in February. By March, he announced sweeping changes in HHS, implementation of workforce reductions, which I'll talk about more specifically, They published a document showing the largest changes ever in discretionary funding, about a 30% change. There was a legal challenge still ongoing in 19 states saying, shouldn't there be a congressional review? I mean, this is something we've all heard a lot, right? And then there is just ongoing implementation, which I'll talk about, of staff reductions in spite of the fact that there has been no review of this. The agencies most impacted, the FDA has had major workforce reductions, and everything is gummed up there. It's not working well. CDC, I'll talk about that very specifically, but they've had massive workforce reductions and really chaotic changes in leadership, and they're currently under an interim director, which they've been for quite a while now. NIH, Jane is going to talk about, and then they lumped all these other things, HRSA, SAMHSA, everything. This is the safety net for children, safety net for people with mental health, illness, addiction services, all the prevention services we have that aren't implemented by the CDC. All of this lumped together under something that's going to be called the Administration for a Healthy America, or AHA. And then big changes in the Center for Medicaid and Medicare Services, which we'll talk about. Some of what I'm going to be talking about is the big, beautiful bill. Some of it is sort of outside and around the edges of the big, beautiful bill, changes in workforce reductions that started before the big, beautiful bill even came to pass. But Johns Hopkins public health messaging on this was, if this all comes to pass, it will represent the biggest rollback of health insurance coverage ever due to federal policy changes. Medicaid, as we all know, Medicaid assists the poorest Americans with health care. What they're going to implement by 2027, so it won't happen before the elections, and the 2026 elections. I think that was very purposeful. But it is this work requirement. Now, this may sound like, oh, no big deal. And that is what a lot of people are saying. Why shouldn't everybody work at least 80 hours per month, either volunteering or in some compensated work? Sounds reasonable. However, one of the things to keep in mind is numerous investigations lately have shown us that 92% of Medicaid recipients who can work do work. So this isn't like it's going to have major impact. But the other thing we know is it is a huge administrative burden. Just imagine all these people that are covered by Medicaid, some extremely disorganized. They may have schizophrenia. They may be depressed. They might be homeless. There's all sorts of a lot of these people have chaotic lives. Could you imagine the burden of having to download documents once a month to prove that you either volunteered for 80 hours a week or you worked? How many volunteers actually have somebody in charge that's willing to provide that documentation? And then how many people who are in this situation, yeah, let me just go to my computer here and, navigate through this complicated site and I'll download these documents. So this is a burden for sure. The largest burden is on the most vulnerable because we have rolled this out in 2 states that I'll talk about. It's really a huge burden. The websites are invariably pretty glitchy. There are all kinds of issues. People have childcare issues, transportation issues, seasonal workers, or people that are on and off. Let's say your company closes and you're a month without a job, but you're looking for a job. You're going to lose your care then, and you're going to have to reapply. So one scenario I read was some poor guy in Tennessee who was a construction worker who had gotten thrown off. No, it was in Arkansas. 3 times in the 1 year that Arkansas had, in spite of the fact that he was working most of the time. One of them was a company closed. The second time was sort of he forgot to upload one document. And the third time was that he had a month between jobs. So in Arkansas, this was rolled out in 2023, this work requirement. 95% of the people in that state on Medicaid at that point either met the exemption. So if you have a large child care burden or if you're extremely disabled, there are some exemptions. So 95% in that state already met the requirement or they qualified under exemption. However, 18,000 individuals lost coverage in the first 7 months of this rollout. There were countless stories of eligible people losing coverage through paperwork glitches, through not being able to get the right documentation from their volunteer job, seasonal workers who couldn't figure out who the right level of person was that was going to give them the paperwork. So eventually, a federal court came in and blocked that and told them they had to resume Medicaid as usual. Georgia, however, has had a work requirement started in 2024. They have spent $86 million. Now, mind you, that $86 million is money that is deducted from actual health care services. So they have spent that to administer those work requirements in 2024. By 2025, early 2025, only 7,000 of 340 eligible individuals had been successful in enrolling in this work plan. And there was absolutely no improvement in employment statistics. For goodness sake, if you're going to do this, maybe employment should go up, right? So make no mistake, they are generating these savings, and this huge administrative burden is at the cost of individuals receiving coverage and health care. So the next kind of travesty here is ACA. So the Affordable Care Act, or Obamacare. Since the Congress first passed this extremely popular piece of legislation, subsidies, they started with subsidies in 2021. And enrollment in the ACA markets actually doubled since those subsidies in 2021, and it has been especially robust in the South, this big enrollment. The biggest impact to nearly all Americans with ACA will occur with the expiration of the subsidies at the end of this year, and as we all know, that was what the government shutdown was all about. The subsidies helped make insurance effectively free for poor Americans, those who are at the poverty level, and they actually offered financial help to anybody who was making up to 4 times the poverty level, or up to an individual $64,000 a year. So anybody making up to that amount could get a subsidy from the federal government. And you can see huge numbers of people with subsidies in states like Florida and Texas, where we know people have been voting against their own interests, as far as I can tell, for a little while now. But so not only at the end of this year, these subsidies will expire unless something happens, a Hail Mary pass. But in addition to that, health premiums were already going to go up. And the health care companies have been telling us that, for the insurance companies telling us that for a while. And partly it's because there's rising hospital costs, rising labor costs, medications become more and more expensive. Just look at our GLP-1s that everybody's using for weight loss. All these things have added to it. But in addition, insurance companies have said flat out, we're increasing premiums because if these subsidies expire, a whole bunch of people are going to be uninsured and our costs are going to go up. And they're right. So they have preemptively increased their premiums. And so it's looking like there would have been a almost 27% increase in premiums without worrying about what's happening with ACA subsidies going away. And so other ACA changes, and I'll talk a little bit more about what the actual numbers are and what that means to people, but just in case it wasn't bad enough, let's make it harder to obtain and maintain insurance by increasing the bureaucracy around it. And so now, up to now, people were automatically renewed and did not have to go through all the paperwork to renew annually. That's gone. And 10 million people used the automatic renewal last year. The open enrollment period has shortened. So the time that you can sign up is shortened by about 6 weeks. It ends December 15th. 40% of people with ACA signed up after December 15th last year, that you're going to have to annually update when you reapply your income, your immigration status, a number of other things. And if you don't do that, you're going to lose your coverage. And new enrollees, the way the ACA worked is if you had a catastrophe or if you lost a job or something big happened and you needed to enroll outside of the open enrollment period, you had about 90 days to prove your eligibility, which is a ton of paperwork and uploading this and that, during which they would give you the subsidy and allow you to be eligible for ACA. That is gone. So you have a tragedy or a catastrophe in your life, you're just gonna have to make do until you can get your application materials in. All this is done. I mean, this is a done deal now. And if we just want to look at the impact in our own state, 600,000 individuals have Affordable Care Act coverage. 97% of those are subsidized. So that's pretty impressive. A family of four, for example, a family of four earning about $80,000 a year, their monthly premiums are now $169, and they will, as of January 1 next year, unless anything happens, go up to about $1,000, and that's a greater than four-fold increase. An individual, who's now paying $154 will go up to about $400, again, 3 times increase. So there will be a $1.5 billion loss to the healthcare system in the state of South Carolina. So it's not only these ACA subsidy problems and the work requirement in Medicaid, but because of the loss of just about 300,000 will drop coverage, another 200,000 they're estimated will become uninsured, which is a 27% increase. Add that to the changes in Medicaid, and one of the estimates is that we'll have 180,000 extra people uninsured in the state of South Carolina. And the biggest impact is on rural hospitals and facilities. And so why is that? Well, Medicaid is about 20% of hospital revenue. So if a whole bunch of people no longer qualify, their revenue goes down. In rural locations, these numbers are even higher. It's about 40 to 50%. Individuals who have lost their coverage and come to the emergency room for whatever reason are going to have to be treated. That is, it's a law. And so that debt, and you imagine everybody's going to come to the emergency room because they no longer have a primary care provider or any way to get care outside of an emergency setting. So that debt in the emergency room, then those people are admitted to the hospital, was something horrible. I mean, they need care, but that debt becomes a loss for the hospital. And hospital costs are going to rise because whenever they have losses, they increase the price of what it costs those who can pay to be in the hospital. Otherwise, they can't operate. It's just, you can't push one part of the system and not expect the bulge somewhere else. And the Congress did, in their infinite wisdom, the big, beautiful bill, set aside $50 billion for rural hospitals, but everybody who knows anything about this estimates that is just a drop in the bucket. It is in no way going to mitigate the harm that's caused by this, and many, many rural hospitals will close because they just simply can't afford to stay open. I have to talk a little bit about SAMHSA. This isn't even, part of it's the big, beautiful bill, but a lot of this is just stuff that's been going on. SAMHSA is the Substance Abuse and Mental Health Authority. It provides funding for services and demonstration projects nationwide: addiction treatment services, harm reduction, HIV, services for the homeless. It is the safety net, by all means, for addictions and mental health. And that goes way beyond just impoverished people. There are so many people with insurance coverage that doesn't adequately cover addiction and mental health. And this is where they go for services. It's going to be moved under AHA, which is probably not a good thing. And there have been cuts to date that are pretty staggering. Up to 50% staff reduction. The prevention branch is completely closed. So all those services around HIV prevention, The 988 crisis line, I don't know if you guys are aware of this, but it was a mandate. I mean, it was a legislature probably 5 or 6 years ago. It's a hotline that is across the country that people can call if they're suicidal or in other really dire straits, and they are linked to resources in their community through this. It's a mandate. That's been terminated completely. All services for LGBTQ have been terminated completely. We had this national household survey that happened once a year that was so informative to practitioners and the public and prevention experts about what is the status of mental health throughout the country. How many people are using cannabinoids? How many people are using, opiates? Is it males, females? What's going on in age groups? One of the best parts of it was sort of the future. They really did a deep dive into what adolescents are using. They go into high schools and stuff. That is gone. We will no longer. And we were the showcase of the world in that. We were the only country that did that really well. And that is the funding for that's cut. And in fact, all of this, just to add on top of it, the 2026 budget calls for an additional $1.1 billion in cuts. The other thing I think that's a real catastrophe here is just women and children and cuts there. Even before the big, beautiful bill, 30% of women in the United States live in U.S. maternal care deserts. So many hospitals have cut their OBGYN services because they actually, the way Medicaid and Medicare pays, and really insurance companies sort of have to follow what's going on in Medicaid and Medicare, it's actually a loss leader for a hospital to do deliveries. So lots of them just cut those services. Title 10 clinics actually provide contraception, STD testing, preventative care, and their funding has already been cut by more than 50%. These are the clinics that actually provide care for people below a certain line, income line. And in many, many states, all of these clinics have closed. For instance, California no longer has any Title 10 clinics. There's also been a 20% cut so far to HRSA's Maternal and Child Health Bureau, which is the one that manages Healthy Start, maternal mental health. It actually allowed for home visitation for women in high-risk situations when their infants came home, people with mental health issues and other things. So in South Carolina alone, the loss of Title 10 has cost us $5.1 million in federal funds, and 74 full-time staff have been let go. We also were one of the states that said Planned Parenthood is now excluded from any Medicaid funding, so nobody can access Planned Parenthood services with the use of Medicaid. And I think this group knows well there are several bills in the legislature that will, number one, give us the strictest abortion ban in the United States with it's a 6-week ban, very few exemptions. And also another bill that would classify abortion as a homicide. And everybody in the chain of that can be prosecuted. The woman, her provider, anybody who talked to her about it, anyway, it's pretty crazy and still under consideration. So all told, the number of Americans living without health insurance will increase by at least 13.7 million, or greater than 50%, by 2034, according to the Congressional Budget Office. So this is, the current administration's estimates. And it is simply not possible for 10 to 15 million people to lose health care coverage and not impact the entire system. It's all related. So even if you say, well, I've got enough money in private insurance, forget it. Your hospitals are going to be a mess. And this law cut more than, the BBB has cut more than $1 trillion in health spending. And that level of health care cut is unprecedented. It's the largest cut to our social safety net in history. And make no mistake again, the only savings that are generated here are by depriving people of health care. There is no other way to save money, from what we're doing in health care. It's only by depriving care. And just cumulative numbers, 11 million could lose health insurance, 18.6 NIH budget cuts, Jane will talk about that, 50%, just the number of medical students whose student loans will be in jeopardy if everything goes through. And 29%, this isn't the big beautiful bill, this is just what's gone on over the last 10 years, is that while inflation has, driven up the cost of everything else, physicians have seen almost a 30% cut in their payments from Medicaid and Medicare. So you see a lot of physicians in private practice that don't take Medicaid, and this is why. I mean, it simply isn't paying what what we need to keep the doors open. So let me move on from that lovely story to vaccines and public health. I'm not really going to talk a lot about policy, mostly just vaccines and what's going on with the CDC. So the mission of the CDC is to protect Americans' health, safety, and security by preventing and controlling disease, injury, and disability. The things they're supposed to respond to are emerging health threats. They're supposed to be doing research to help improve health decisions. They're supposed to be promoting healthy behaviors and healthy environments, developing and distributing vaccines and prevention guidelines, and strengthening the public health infrastructure. That's their primary goals. Mostly although cutting really the entire budget tremendously, most of the specific impacts have been around vaccine and prevention guidelines. But let me just, go back a little bit to talk about in January, I don't know if you remember this, Jane will talk about it too, but all external communications and scientific reports were put on pause for 2 months almost. And what that meant, they took down every single website from HRSA, from SAMHSA, and the CDC. And let me tell you, the CDC websites are really important. They inform not only the public what's the latest on vaccine guidelines, but physicians and practitioners look at them all the time. There's all kinds of guidelines and advisories about emerging health issues. These are really important. If I wanted information on something that I wasn't really current on, I'd go to the CDC websites. Everything was wiped down, and when they were put back up, it was probably 25% that went back up. So they just, deep sixed a ton of things that had been really well researched. There were some guidelines that I had worked on that were on there. They're gone, So in February, all vaccine promotion campaigns were shelved. And in June, all 17 members of the key vaccine advisory panel were removed, and a new panel was appointed, and they really didn't have very much expertise in vaccines, and there were at least 4 members that had pretty well-known anti-vax sentiments. In September, I don't know if you guys saw that very combative session with RFK and the Senate, but one of the things he said there was, as if this was something that was happening, an external force was causing it. The CDC has lost the public trust and promised to tell the truth. He promised to tell the truth. And if there's anything that has caused the CDC to lose public trust, it's been what's been coming out of the leadership of the country. And really the cuts to it. So one of the most chaotic things that I think is really, sort of a signature of what's going on was the CDC leadership. So in July, for the first time, the Congress said, we want to weigh in and we want to approve the new CDC leadership. So they confirmed Susan Manares, a very qualified woman, to run the CDC. About a month or so later, Kennedy calls her in and asks her to just blanket, I want you to approve all recommendations from our new vaccine advisory board. You're not allowed to question them, and I want you to fire these 5 people, all senior CDC executives. She refused, and she was fired. And she was fired, of course, over a tweet or some other social media thing, which just basically said she's no longer the director of the CDC. And so there was a big hearing about this, and the CDC is still without a director. They're still under interim leadership. So what's happening with vaccines? This actually isn't as bad as you might think. I think the vaccine story is more or less what's actually gone on from the CDC, except with a couple of notable exceptions. but more a general buzz from the leadership of the country, sort of ignorant of the science around this, just kind of spreading doubt and seeding, discomfort about the use of vaccines. Except, however, that COVID-19 vaccine was reclassified. It used to be mandatory in certain populations. It is now reclassified as something that shared clinical decision-making. In other words, should you take it? I don't know. Have a discussion with your doctor and see what he thinks. So, and they are not routinely, should not be routinely delivered, and there's no risk-based stratification around COVID vaccines, which the science would tell you that's pretty crazy. But anyway, and the big problem with that, what scared everybody was, are insurance companies going to take the lead from this? So when a vaccine's not mandated, that can be, well, we don't need to cover that anymore. So that was the big fear about that. I don't think that has actually played out. And in terms of measles, Trump actually encouraged, if you remember the big speech about acetaminophen, right? Acetaminophen causing, birth defects and autism in kids, zero evidence. But in that press conference, he also encouraged people to use separate vaccines instead of MMR, measles, rubella. He said, use them separately. However, standalone versions of this are not now available in the United States. They're going to do separate vaccines, but here he was encouraging that. Hepatitis B, there is some controversy. Right now, it is administered, pretty much at birth or in early infancy. That's a current recommendation. There, fortunately, went to this new committee, and fortunately, they were smart enough. It gave me a little hope. They said, we don't know enough about it. We're not going to vote on it now because, if an infant, it's transmitted from the mother. If an infant, if it's transmitted to the child, that child is going to have lifelong problems, liver problems, and hepatitis B. That is why, in spite of the fact that it's only a small number of infants, they are recommended because the vaccine is thought to be very safe and no problem. So it's sort of it's a preventative measure, and that's somewhat controversial. And thank goodness the committee decided not to weigh in on that yet. RSV, if anything, they've actually made that vaccine more available, but they are going to be studying the childhood immunization schedule. And as you all have heard, Florida has announced a plan to end all state-level vaccine mandates, including kids going to school, which is sort of one of the basic vaccination schedules that everybody pretty uniformly has agreed to, except now Florida's bowing out and Texas will probably be next. Measles is a little bit of a tragic story. There was a large surge in cases in early 2025. Again, you can't say exactly what that was due to, but there has been a ton of skepticism that's just sort of been spread from the top about vaccines. There are 800 cases and 3 deaths in communities that had low vaccination rates. In the early summer of 2025, there were 1,000 confirmed cases in the United States, the highest since what we called elimination in 2000. In fall of 2025, probably everybody heard there was an outbreak in Spartanburg, South Carolina. And just to be clear, we really do need 95%. Measles is extremely contagious, and so because of that, you do need a 95% of or higher rate of immunization in your group in order to really have that herd immunity. And there has just been drops in general in childhood vaccinations and misinformation and vaccine hesitancy. And Kennedy did weigh in, to be fair, on the measles vaccine somewhere in spring, early summer. He said, yeah, vaccines do limit spread, but he did raise in the same breath concerns about the side effects, which can include seizures and pneumonia. So God forbid he should just give a clear, unambiguous message because people are dying of measles. And I think with that, I'm going to stop and turn this over to Jane.
All right. Well, I'm very happy to be following up on this cheerful message that Kathleen has given us. And yeah, it's not going to get any better with my talk. So I'm really going to focus on biomedical research since that's the topic today. And just note the same disclaimer. Oh yeah, how did you go back? Arrows? Okay, so I first want to point out how important NIH-funded research is for our country. Research is not just fun things for academics to do in an ivory tower. It actually gives us results. And this is showing us the beneficial outcomes of NIH funding. I won't go through every example, but we know that disease is very costly. So the top example is showing the cost of cancer care in the US in 2020. It's a little bit old, but $208 billion for the cost of that. However, with NIH-funded research, there have been very positive outcomes that give us hope. So the number of lives that have been saved by cancer research since 1991 amounts to about 3.8 million. So investing NIH dollars in research really pays off and gives us some hope. It's also cardiovascular disease and Alzheimer's. It's been funding those for obviously many decades. NIH-funded research has reduced the cardiovascular rate of cardiovascular disease by about 56% over a decade. And although Alzheimer's, we're still working on treatments, there are currently 68 clinical trials funded by NIH. And so we're working towards that, hoping to get hopeful outcomes soon. But there's a direct relationship between how much funding there is and how much success there is for different diseases. Just a few other factoids. Over 350 new drugs all stemmed from NIH-funded research and were approved by the FDA. And it's not just the health outcomes that we can be grateful for the NIH for. There are economic impacts. So as shown there, in 2019, research conducted by NIH-funded research actually led to or generated $33 billion in gross domestic product and over 350,000 jobs related to that research. So investing in research pays off not just for the outcomes of finding treatments, but also for all of us and having strong economic impacts. So I just want to make these points that NIH is the major federal source of funding for academic research in our country. I think Kathleen cited this number as nearly $19 billion in NIH awards to medical schools, medical universities. And just as an example, MUSC obviously receives grants from NIH, and in fiscal year 2024, there was about $114 million in grant awards just for the College of Medicine. That doesn't include other colleges at MUSC. So locally, we rely on NIH funding it has local economic impacts and, of course, the outcomes that we're hoping for, which is cures for disease. It is the lifeblood of academic research in the US. Yes, there's pharma, they have their research, but they have different goals and missions. They need to make profit. Academic research is not a profit-making enterprise. Universities are not independently wealthy, so when you cut federal funding for research, universities do not have the budget and resources to take up the slack. So although this is kind of small, I'm going to turn this way because I can read this. So this is just from a recent report, publicly available, the revenues and expenditures for MUSC. And what I want to point out are the grants and contracts. The dollar amount is there. It's about $280 million, or about 26% of MUSC's revenues that they receive. The expenditures related to research are shown here, and that amounts to about 25%. So it's pretty much a one-to-one match. You get money for research, you can fund research. If you reduce the funding, that research goes away. So if we reduce the revenues by 30%, which is what's 30% or more budget cuts to NIH, funding at universities, or research at universities, will decrease by that amount. Very few universities can, independently sustain the research activities. You might say, well, MUSC is a public university. Why can't we rely on the state? I was hoping some people would laugh. Okay. So MUSC, although it is a public university, it really only gets about 11% of its revenues from the state. That was actually higher than I had heard, but those are just those are the recurring ones that stay with MUSC. So yes, we are a state, or I shouldn't say we. MUSC is a state institution, and it gets some of its revenues from clinical operations, but that has to go for clinical activities. So any way you look at it, if you reduce federal funding for research, you're going to basically diminish the research activities at any university. Okay, so here's a similar timeline. It has a couple of the same things that Kathleen talked about, including the communications freeze, but I think Kathleen covered that very nicely. That was back in January. Also, we've probably all heard the executive order that withdrew the U.S. from the World Health Organization. And while I'm talking about NIH in this talk, I'm going to give you data about more broadly some of these actions that affect research, maybe not in a truly direct way, but this WHO withdrawal obviously sets the stage for, a context in which we are not, working with the rest of the world. We're not being collaborative. There are many sort of ripple effects of this. What did I do? Okay, it's all good. Okay, so in February, there was this NIH issued guidance in terms of capping indirect costs on research grants, and I'll talk a bit about that in more detail. There was centralization, orders to centralize the grant review process. While this may sound like, oh, that sounds very efficient, well, it's really an opportunity that will allow for more administrative meddling in the grant review process, which of course can dictate the direction of research in the country, as opposed to it being really independent, politically independent. And so there's kind of these threats coming from all angles. In April, NIH rescinded its internal scientific integrity policy. To me, that just sounds like a bad idea right up front. It's intended to protect research and communications from political interference. The policy was basically just, let's do away with it. And then, of course, budget cuts. I'll talk a lot more about that. But in April, NIH was ordered to cut $2.6 billion in contracts. That's a pretty big number. And then later that month, there was a report showing that indeed 2.3 billion fewer dollars in new grants since the start of the calendar year. So that's just like 4 months. Honestly, these are unprecedented and catastrophic actions. And then in May, the proposed budget is going to cut NIH by 40%, or $18 billion. And however, thankfully in June, a federal judge ruled NIH budget cuts were void and illegal. Okay, and then I think we have one other thing here. Yes, and then, I don't know, this is just sowing chaos. And this was in end of July. The administration briefly halted all NIH research funding, but then rescinded that the same day. so it's like, let's cause heart attacks to everybody around us, and then, oh, we're just kidding, But you can see that these are some not well thought out actions. Yeah. Okay, so I'm going to focus on a few different topics that are all really causing huge threats to biomedical research. I'm going to talk about extreme budget cuts, this indirect cost rate reduction, canceled and delayed grants, and the government shutdown, and an idea forward funding that is already happening. And I'm just trying to convince you here that these attacks are pretty much going to cripple biomedical research if they all were to happen. Some are already happening, some are not. So extreme budget cuts, here's some numbers, and this is not just NIH specific. It's across all government agencies that fund research in the US. And it's just comparing from FY 2024 to the proposed change for the next fiscal year. And you can see that basic and applied research, research and development are all being cut, those are kind of off, but by 30% or more. And it's mostly non-defense research and development. There is some reduction for defense-related research, but it's mostly the non-defense sector. These are catastrophic. I mean, like 30% decrease if someone told you your paycheck, oh, all of a sudden it's going to be going down by 30%. We all know how difficult that would be. Okay, so with these budget cuts, obviously far fewer grants are going to be awarded. There's just not going to be the capacity for that. But the current status is that both chambers of Congress have now rejected Trump's proposed 40% cut. But I think that's fairly recent. But I think we see from the timeline and other actions that there's going to be continued punches coming along in some other way if that's not approved. Okay, so indirect cost rate reduction. What are those? So here, this is a figure. You probably can't read any of that, so I'm going to read it for you. But on the left side, we're showing what direct costs are versus, on the right side, indirect costs. So when a grant is awarded to a university, it's a certain dollar amount. Of that amount, there are the direct costs, which are related to the project itself, okay? So this is like you propose, to do a specific project. You need certain personnel to run the study. You need supplies, equipment, sometimes tuition or stipend for graduate students or going to scientific meetings. That's all related to that project only. Each university has negotiated an indirect cost rate with NIH or other federal agency. It's different for different universities, but the indirect cost rate is the amount, it's sort of like overhead, that you apply to the direct costs. And the university receives these indirect costs for more general operations that are related to research. So things like, personnel, administrative and financial personnel, janitorial staff, just people who keep the university running and support the research mission. Things like radiation safety. You've got, obviously, utilities, library. You've got general research equipment, and the staff that make sure all of the research is in compliance with regulations. So all of that is covered by indirect costs at a university. Okay, I think that's all I want to say there. And then there are things that are not covered by either, like lobbies and classrooms. So on the left is how things are currently. It says previously here, but luckily this 15% indirect cost rate, which was proposed in February 2025, has not happened yet. But if you have a project that costs $200K to conduct that research, you might have to modify that a little bit because not everything is subject to an indirect cost. But if a university has negotiated a 50% indirect cost rate, you can see the math there. they're going to get $90,000 off of that grant for the indirect costs. If what is being proposed were, to come to pass, then reducing it by 15%, obviously you're reducing the total award, and that's a $63,000 reduction in grant dollars, which if you multiply that by several hundred or thousand grants at a university, and most grants are a lot more than that, 200,000 is a pretty small grant, you can just imagine the loss of funding that the university is going to experience for their operations to support research. The current status, though, luckily, is that it remains blocked, but there are legal appeals ongoing, so it is not a complete story yet. Okay, that's just what I just said. And then canceled and delayed grants. I'm not going to go through this in great detail, but I just want to make a couple points. When a researcher submits a grant from a university, it's a long process. From the time of having the idea to actually getting the award, if you are lucky enough to get the award, it's probably about a year. So any actions that delay that process delay the progress of research in our country. So when a grant is awarded, if you're lucky enough to have gotten one, it usually lasts 3 to 5 years, and it has a certain termination date. So if you requested 3 years for your project, there's an official end date for that. There have been unprecedented numbers of grants that have been canceled before their official termination date. And I got these, I have a lot of stuff here, but we're going to skip all this for now. So grantwitness.us has compiled this information. It's obviously not from a government source because they're not being very transparent about that information. Wonder why. So this has been compiled through independent resources, but this is just showing which states have had the most canceled grants. So obviously orange, yellow colors have been the most impacted. And this is just by number of grants. And so if we look at South Carolina, moderately impacted. And that's not a lot of canceled grants, it sounds like, but so ever impacted, these were grants where the investigator was told, we're ending your grant. Just suddenly before, right in the middle of the research, really no explanation given, something very vague, like it's not aligned with a programmatic interest. I don't know the exact terminology, but it's something really vague. Several grants across our, more than several, but there have been a lot of grants that have been reinstated after being told they were terminated. In South Carolina, that was just 2 of them. But the estimated current loss just for those grants that were ever impacted is about $9 million in research funding. So small state, we have less research dollars coming in, but somewhere like New York, $250 million expected or estimated loss. California, over $500 million. And it's not just states that tend to be blue on our political spectrum. Texas, also pretty impacted. They're in this map, in orange color, so most are very strongly impacted, with an estimated loss of about $81 million. So from this grant.witness website, they have all of this in an Excel spreadsheet. So you can go and download it and do what you want with it. What they also have is a column in that sheet of the terminology or words from a list that was published, I know at least by the New York Times, of flagged words that relate to all of the canceled grants. So being a data geek, I downloaded this, this Excel sheet, and then I created a word cloud from all the words that were flagged from these canceled grants, and here it is. So obviously the bigger the word, the more often it appeared in these canceled grants, and you can read it. The writing is there on the wall, like literally on the wall. But it's very disturbing. Research that involves women, canceled. Minorities, canceled. Racial and gender issues, Black, Hispanic, diversity. I mean, you can see what's going on here. I just find this very disturbing in and of itself, but I also want to point out the irony of this. As I was submitting my last grant, we are required to fill out certain forms for NIH grants. If you do, this example is if you do human subjects research, you have to fill this form out, and I've highlighted all of the terms that are on this flagged list as part of our grant submissions. So I don't really know what to say except to use this emoji here. It's just mind-blowing that I have to include these words, yet I risk my grant getting canceled or rejected even before it's scientifically reviewed because of these words. And that has been happening, which I had never heard of ever happening before. I don't know, Kathleen, have you ever heard of that? Yeah, so that's new this year for all of us. So anyway, that is quite a tragedy, and it's never happened before as long as I've been an academic. Okay, the government shutdown, I won't like belabor this, but we all know government shutdowns have a negative impact on us economically, but also labor force, and it really slows the progress of research, externally funded or external research and intramural research as well, because NIH has one of, the premier, it's like the premier research labs in our country, many of them, and in the world. So it's also affecting the intramural research program at NIH, which interacts very closely with extramural research. Okay, I'm going to end on this. I just want you guys to know what forward funding is and how it impacts the biomedical research funding more broadly. So when a university receives a grant award, it's usually, if it's a 4-year award, it's paid out in one-year chunks, okay? So each year, the principal investigator has to write a progress report and be accountable for the federal money, the taxpayer money. If you make good progress, you get the next year of funding, et cetera. So there's an accountability in this process. This is how it currently works. And if we talk about dollars, if you have $2 million in the NIH budget, it can actually fund 4 different projects. So, for that same $2 million in that year. The next year, the $2 million can be used for 4 other projects, or the same projects if they're ongoing. With the proposed, well, not proposed, it's actually been implemented, this forward funding or multi-year funding concept, NIH has been told you have to pay out the full amount of that award in the first year for that investigator. In a way, that sounds like a good thing. It's like, oh, yay. As an investigator, it's like, oh, I have $2 million now instead of $500 million. But it's actually a tragedy because with that $2 million, NIH can only fund that one project. It cannot fund the other 3 projects in that year. And you lose the accountability of having to file progress reports and be accountable for the taxpayer dollars. So I know you can't read that graph on the right, but hopefully you can see the lines. It's just showing from fiscal year 2021 to fiscal year 2026 the number of grants that have been funded now. So the last, can I use the pointer here? Oh, yeah, okay, sorry. So this is fiscal year 2024, a precipitous drop from over 10,000 funded to, I think that's just over 6,000, and it's expected to go down again next year. And it's not solely due to this, but forward funding is already having a huge impact. So NIH was told this year you have to fund 50% of the grants using forward funding, and next fiscal year it's going to be 100%. So now we're shrinking the pool of grants that are going to be funded. I just want to also point out that it's extremely difficult to get grants, to get a grant. Success rates, I had it up there somewhere, but for the National Cancer Institute, Success rate this past year has been about 14%. So 14% of grants that, that have applied have gotten funded. That's going to go down to about 4% next year due to all of the impact of all of these factors. So it's going to be even more competitive, and it's just like, getting hit from so many different directions. Luckily, some of these are not implemented yet, but I feel like we need to fight these things because if they all were to be implemented, it would really just cripple academic research in this country, and I don't think we should let that happen. Similar things are happening in other areas of research as well. It's not just biomedical. So I'm going to stop there, and I guess we'll take questions.
I don't know how this works.
Use this one too.
Is this one on?
Yeah, they both are.
So now we're going to have question and answers for the two of you. You want to stand up?
Universities have been asked to sign on to an agreement with the administration, and there's been a threat of penalties if they do not. Two questions. How do you see that playing out with NIH grants? And second question, has MUSC signed?
I think there were 9 universities. Yeah, there were 9 universities that were asked to sign, and the only one that agreed was University of Texas. I think Dartmouth, Penn, I can't remember what the other 8 were. And all of the others, the 8 that didn't, said this is just in defiance of academic freedom. One of the contingencies in there was if they signed this, they would have better access to funding, like NIH funding, than other universities. And again, the 8 that stood firm said, this is a merit-based system, and we want it to stay that way. We don't want preferential access to scientific grants. It's merit-based, and it should be that way. So I haven't heard, MUSC hasn't been asked to sign that I know of, and I really haven't heard of anything except those first 9, and I think they were rebuffed so sternly, thank goodness, by the academic enterprise that I'm hoping we won't hear much about that.
First of all, thank you for telling us about the university. I'm still employed by a research company in the outskirts of Washington, D.C. in Crystal City, Virginia. It is the American Institutes for Research, and I'm one of their senior editors, and I get your word salad instantly. All those words I couldn't use because I do their reports on contracts and grants. The company was reduced on July 29th instantly of all our major contracts and grants from HHS. So we lost probably, I'm not on the upper management of the company, but we lost probably our health economists, our research directors, our research program people. And so when the federal government has a grant or a contract, they also go not only to universities, but they go to the research companies. And so they have sort of a duplication, but the research companies are often the ones that implement with the client, who is the federal government, these programs. So the federal government now is at a loss for anybody to help them implement their own programs. So it's not a question. I was just going to say there's a whole lot more out there. And all those people are now either furloughed or fired, or they don't know. I mean, in the federal government contracting business. And just a personal thing. Yesterday, I happened to call I'm on Medicare, my Part D, I have WellCare, and I said, I want my 2026 formulary, because I have some very big medical things that I need. Part D is your medications. And she said, well, it's pending. I said, well, I've got to make a decision. And so she said she would send me the stuff, but it's not really readily available. And she says, I hope you know it's going to be double or triple. And I said, what? And so I'm very fortunate to have the opportunity to also have TRICARE, which is a wraparound service. I read about that, and we're afraid of that now, of going. So I think people in both the government funded things. So thank you. That was a bit much to say, but I think it's all a concern.
Really, thank you for your input. I just want to say I did see, there was so much more going on to Medicaid and affordable care that was just, but truly the one thing that's in the big beautiful bill is that all subsidies for Medicare Part D are going to be tremendously reduced. So seniors in the room can expect to pay much more for their pharmacy benefit. That was the one thing about Medicare that was clear.
And I just want to say thank you for your insights, that it's not just academic research being affected, it's much broader, but that's what I focused on here. But I hope we all understand the ripple effects beyond the academic institutions as well for research.
Things eventually go better, and how long will it take to recover from what's going on here? That's the scariest part.
Yes, I have no estimates of that, and I mean, I don't know. I've been trying to think about that, like how hard is it to reinstate some of these processes which are already bureaucratically crippling. And the reinstatement of them, I can only imagine. I don't know if you have any insights.
Yeah, I don't have any insights, but what I do, if you take apart a lab and, defund a lab and all the equipment goes and this and that, it would take many years. If a hospital closes, I mean, it's going to take a big lift to get that reopened again. So I would say the potential impacts are, a 10 to 20-year prospect, and that's if it ended in a couple of years.
Okay, I just want to say that was a fantastic presentation, and I feel like we should all get up a GoFundMe and let you take this show on the road. And so part of my question is how many other places have you taken this presentation, and how do you get it? I know we live on sound bites, and this is not exactly a sound bite of a presentation, but legislators and thoughtful people and voters need to understand the impacts.
Well, this is the first time we've presented this. But it's been, I'm very grateful for the opportunity to have prepared this presentation for you all. I agree that I'd love to get this message out more. There are like sound bites everywhere. There is a lot of information out there. The problem is it's probably not very centralized. I know Kathleen has a colleague, I believe, who is sort of keeping track of a lot of information, at least research-wise. Yeah. UCLA.
Yeah, it sends it out to big lister. But no, we've never given this before, and it was actually so very interesting just pulling it together because there was, just information from all over the place. But
where is the pressure going to come? Because, I mean, these things are just, terrible
they're
policies.
devastating, right?
Is it just going to be, I feel like we've been waiting for everybody to be feeling so much pain from their insurance premium or something else, and that it's kind of like the addict has to hit the bottom and then they realize they need help. But it feels like this is just of a magnitude that...
I think that's what this organization, SINO, is all about. It's like trying to turn facts into action. And one of the first ways to do that is just to make the information, is to shout it from the rooftops as much as possible, and then, sort of formulate some community actions as a result.
So that's what my question was about. So once we know all of this, I mean, we have 2 senators and all but 1 representative in the federal level who all would have supported the big, beautiful bill. And, they should be accountable to us. So we need to make them extremely uncomfortable, which is going to require constant calling and contact on every level from not just people who voted on one side of the aisle, but people who are going to be impacted no matter whether they vote for one party or the other. So I think that's where we need to get the organization, because they clearly feel uncomfortable being oppositional to the proponents of these kinds of cuts. They need to feel more uncomfortable being oppositional to the people of South Carolina.
Absolutely.
Yes.
Also, could we post your presentation on our newsfeed?
Yeah, sure.
Sure.
Great. Thank you.
I just wanted to say that this presentation is going to be on YouTube. In fact, it should be on there now. So go to SINO's Facebook page, spread the word on your own social media, and share the link to Circular Congregational's YouTube channel. And that way you can help get this presentation to a lot more people. We're having at least 3 times as many people watching the YouTube version as we have coming to the actual presentations. So our information is getting out, and y'all can all help get it out even further. So thank you for doing that.
Oh, wonderful.
I knew you would look familiar.
Thank you. I appreciate y'all sharing your message today. I'm actually work in higher education, and I have for the past 20 years here in Charleston area, financial services for students, FAFSAs, all that kind of great stuff. Just spent this past week at a conference discussing the great, wonderful, beautiful bill situation. And it's following the same pattern that y'all were experiencing. And I was sitting here amazed that everything y'all are going through, we're going through with the dismantling of the Department of Education. Federal work studies being cut by 50%. This is those students that are highest at need to receive funding. They work in the school system. 50% is being cut. Supplemental educational opportunity grants is being cut by 50%. Changes to the loan systems adversely impacting the most needy are in progress and being implemented. And the scariest part about the whole thing is all these initiatives that are going to be playing out, there's no way we can prepare for audits or have no understanding of what to do or how to brace for these because they're so cryptic and so vague that you can't get to the core of what actually is expected.
Yes.
It's a big problem. So you're not alone.
Yes. Well, I would say I'd love to hear a SINO presentation on that, on the education. And one thing that I did not include in my talk is biomedical research dollars fund training of next generation scientists. And at MUSC, the grants that have been canceled have almost, the majority have been training, grants to train undergraduate, postgrads, graduate students. Of course, they were canceled because they had some aspect of diversity in their grants. But it's a tragedy.
We had to strip those from our entire
Yes. Yeah. Yes. Well, thank you for sharing that.
Yeah, and the wording we got when we on all these grants was that the this program is not consistent with the priorities of the new administration. That's what that was like. That was the punchline on all of it. Not consistent with the priorities.
So I know we can call Senator Graham and Senator Scott, and I don't expect to have much influence, quite frankly, on them. But I would think that the leaders of MUSC, and I mean the top leaders of MUSC, you were very careful to say you don't represent. Is MUSC representing itself or its leaders fighting for this funding, for their survival?
Would you like to speak?
I don't.
Yeah. You know, I think because we are such a red state, and we are to some extent dependent on, you know, we do get some state funding, and it's more than just the some state funding. There's other, you know, there's other ways, you know, that the medical school or the medical university is supported by, so, you know, for instance, allowing a nursing school, expanding the dental school. So it's not just, you know, there's all kinds of, you know, funding that comes from the state. I just think there's been some real hesitancy about speaking out. I think, and I don't think that reflects necessarily, again, the private opinions of anybody in leadership. I just think in terms of representing the institution, my impression is that they just, you know, haven't wanted to go there because they don't want to become a big target, you know. And that's, you know, I get that sounds a little weak, but look at all the law firms that folded, and, you know, I mean, it's just, you know, it's been, you know, this whole mentality of really persecuting your enemies is just become so prevalent that I think a lot of people want to keep their heads down.
And I mean, I'll just add that I don't think they're just sticking their head in the sand. I do know leaders have been meeting at MUSC, but it's the public voicing that Kathleen just outlined that where there's hesitancy. And I'm not speaking on behalf of MUSC, but I am aware that the leaders, many of the leaders are very concerned and have been trying to come up with contingency plans for sure.
To be honest, lots of workarounds. There's lots of workarounds in progress because everybody wants to continue the diversity initiatives and, you know, all of that stuff. I think in people's core principles, they're still there. It's just putting yourself in the center of the bullseye is, I think, a little bit frightening right now because of the way things are going.
I'd just like to add one thing to that, and that is that there are two reasons to call your representatives and your congressmen anytime anything bugs you. First of all, it makes you feel better. It gets it off your chest, and somebody else doesn't have to hear you rant. The second thing is it does have an effect. The more calls they get, when that phone is ringing off the hook, they get nervous because those are voters calling. So go ahead and call as often as you want because they do, even though they won't admit it, they do hear.
I'd just like to possibly reframe this whole endeavor, the imagination that led to the creation of SINO in the first place. It does look like a massive effort in disaster risk reduction. And in the field of disaster risk reduction, there's a mathematical formula that says disaster risk is equal to hazard times vulnerability over resilience capacity. And the note that I took just now is that what you esteemed physicians have made very clear is that there's an intentional effort to suppress knowledge sharing. So there's something called educational vulnerability, and that is a persistent condition in which something you don't know can amplify your risk of harm. So if SINO is engaged in this active and intentional knowledge sharing, and people will go like, oh, how did I not know that? How did I not know that? And so we're not even allowed to use the word woke anymore, but for God's sake, isn't that what we're doing? And so I don't know how we create sound bites, but the information that you shared today needs to be widely shared, like a virus, against which there is no vaccine. So I'd just like to throw that out there.
We should end on that. I think that's a perfect place to end, I think.
Yeah. Thank you so much.
I would like to add also that there's quite a network in Charleston of these like social justice groups, SINO 5051, Indivisible, all sorts of different groups that I think have at least a loose affiliation with each other, and so that the more that we are sharing all of this stuff with each other and our own sort of bases, that is a great way to get the information out there also.
Okay, thank you.
Thank you. Y'all, Jane and Kathleen, thank you so much for this presentation today. It was incredible. Thank you. It was incredibly informative, very depressing, and then we're going to have that quotient thing where we're resilient. So, so we just need to spread the word and send this link to people so they can listen to it. And if you've got contacts in reporters or periodicals, magazines, any kind of thing like that that you can connect us with, then we can spread this in a greater way. So one of the things we were going to ask for today is anyone who's got a connection where we can get this information out. We're looking for help with PR and with anybody has a speaker idea. Please talk to Jan. We really want to keep educating. This is what this monthly practice is all about. And we are working hand in hand with with all the other organizations like 50501 and the Low Country Liberal Ladies, and I mean, you name it. We're really trying to reach also across the aisle, and we're including folks who are conservative, that aren't all the way to the right, but that we can see some eye to eye with and have a civil conversation, and that's what we're looking for. So I'm going to do this very quickly because I know this has been a long time sitting. I just want to let y'all know that the silence is not an option. Board of directors, or the wheelies as we call ourselves, had a retreat a couple of weeks ago, and we were actually led by my dear friend Sandy Morkel, who's the president and change agent of Inspired Philanthropy for Solutions of the Greater Good. And we had a great retreat. Did I say that right? Okay. We had a great retreat and our planning and creating programs, and more is coming to us, like the fact that Governor David Beasley is going to speak with us on the 3rd of December is big. And he's been working on world hunger. That's been one of his issues lately. So that's something that we're going to tackle and talk about on December 3rd. But he's been doing a lot of things nationally and internationally. They're going to be very informative. And look for the newsletter that comes out, because in that it'll have more information about what topics we're going to touch. But just wanted to let you know that the folks that are behind SINO, the women at the wheel are Elizabeth Lulu Colbert-Bush is a co-director of SINO, and I am the other co-director. I'm Mackie Moore, for anybody who doesn't know. And then I wanted to thank these women also for Sally King Gilreath is the secretary. Will you stand up just so people know your face? Is the secretary. We have Diane Agapour is the treasurer, and we have Jan Anderson over here as the chair of our programming. So, and then we also are joined by Greg Smythe, Susan Dunn, Kay Kuntz, founder Jane Aiken, and fellow brainstormers with Jane Aiken, Barbara Hagerty, Susan Dunn, and Greg Smythe, who are the original prime movers of SINO. So I just want to thank them so much for all of the help and support. We are, yeah. Oh, and I'm so sorry. She's on here too. And Harriet McLeod. Harriet McLeod, who is a retired Reuters reporter. So if y'all saw our email chains or text chains every day, it's Harriet, is this really true? And she is our fact checker. So we actually have a really great fact checker, and we really try to be on the money here with what we're educating about. So we have looked at who are we, what do we want to be. We've talked about in the future forming a 501c3, maybe C3 and C4 if we want to do government advocacy. But we are going to take things slowly. And for the first couple of years, we're just getting our legs under us and trying to create great programs. So that being said, it's not necessarily a tax write-off at the moment, but if you are so inclined, we would appreciate any donations that you could make that would help us just keep the educational programs going. We're not spending big money on anything, and we're all doing all the work. But when it comes to just paying for the church AV and the use of the space for the utilities, that kind of thing, that would be so great and so helpful. So just wanted to put that out there. And you can see any of the SINO ladies, if you want to write a check, and if you want to Venmo, just let us know, and I've sent that out in a newsletter. That's pretty much in every newsletter, the links for that. Please follow our social media pages, and the more you like each post, the more it spreads. I don't know if y'all know that. So it's really helpful when you get on there to just like and comment, just hi or an emoji or anything, because literally every comment, it goes to more people. And that's how we spread the news. Let's see. Okay, we do need some help. We need some volunteers. So anybody who is interested in helping with PR, with building a website, with helping to manage the social media, especially the Facebook page, would be very helpful. We need meeting greeters. We need speaker connections, topic ideas, and don't forget, we need protest leaders, because we have created in Charleston sort of a rebellious little act. We were told that you have to have a permit to protest if you have 25 people or more. Well, you go to get your permit and you get put in the corner somewhere, like Brittlebank Park or Hampton Park, which are lovely parks, but nobody drives by them, and nobody can see you. So what we came up with is the idea of 24 people per location popping up all over Charleston. And we have now about 12 locations, and we're going to try to keep increasing that. So on the second Sunday of every month, from 2 to 3, we pop up all over Charleston with 24 people with a number pinned on them, so nobody can, you can tell how many people there are. And we're getting the word out there. And last Sunday was really kind of amazing. We were at the Customs House, and there were 24 of us with our pinned numbers on. I was number 5. And there were 2 police cars that watched us the entire hour, but didn't do anything. We would wave at them. But it was very peaceful. And we had a few people that walked by and challenged us. Only one was very nasty. The other 2 were just mildly. And mostly we got cheers, we got horns honking, we got people from windows across the street waving. I mean, it was really neat. The support out there and the courage that people are now having to come forward since this last election is inspiring. I think finally we're seeing that the majority of Americans are just like us and want the same things we want. The majority. So, I know we're fighting some factions, but our job here is to educate and to have civil discussion. And that's what we're going to keep. That's what we're going to keep doing. So if you'd like to be a protest leader for one of the pop-up protests, please let me know. We'd love to have you. The next one is second Sunday of December, which is December 14th, and there'll be a sign up for that. You can find that on our Facebook page or in our newsletter. And again, don't forget David Beasley, the governor of South Carolina, I wish I could give you the date right this second, but I can't remember it. It was a while ago. And, but anyway, he's very involved in world hunger and many other things. He'll be speaking December 3rd from 6 to 7:30. And I just want to know if anybody has any questions or any ideas or thoughts that you would like to share. Okay, do we have where's the other mic? Oh, here it is. I have my pen out.
Hey, I'm Bonnie Cleveland. I know some of you in this room. I'm one of the SINO pop-up organizers at City Hall, so join me some second Sunday. I also wanted to let you know about some other upcoming protests. Next weekend, on Saturday, I'm doing another kind of protest to challenge the city's ordinance, which is a march from 5 different garage locations around Charleston. We're going to march to and around Marion Square, down to City Hall, and then back up. The police, in a delayed fashion, finally responded to my permit request and tried to move me to just Meeting Street from one garage, but we're going to go ahead and march anyway. So if you're brave enough to march in a unpermitted protest, join us. You can go to charlestonprotest.org. That afternoon, 5051 is doing a protest also at 1 o'clock in North Charleston. I don't want to tell you the wrong place, so look that up or get in touch with me if you want to know about that protest. And then there are several others around town that if you want to find out about that are weekly protests, let me know and I'll give you the info. Thank you.
Thank you.
Many of these, I think, are on you post on our website, don't you?
Oh, yes. I'm going to put, most of it is posted on our Facebook page. So I think everything she just talked about, other than the one where we converge from the garages. So I'll get that info and put that on there.
The protests are fun, too. If
They
you
are
go,
fun.
I've done a couple of them, and it's just really rewarding.
Oh, yeah. Same.
Hi. I am a different member. I am a member. I have been since the first meeting, Mary Edna Sullivan, and I don't do Facebook. I gave up social media because it absorbs way too much of your time. I don't do any of it. So I haven't been protesting because of this Facebook issue on the website. I mean, on your email, because since I don't do it, if you go into it, you have to join. And it took me eons to get off it when I was on it in the past. And I would like to be part of the pop-ups, but I haven't been able to figure out how to get a hold of a person at the time and wherever. So,
do you receive our newsletter? Are you on
I get the email, yes.
Okay, it's all in every newsletter has it as well.
But it keeps saying Facebook.
Oh, but I have there's a sign up Genius link.
Okay.
And so we always have a link on there. And you can go right to that and sign up, or you can email sino.charleston@gmail.com. If you're having trouble with the sign up Genius, sino.charleston@gmail and say, I want to protest. I'll reach back out to you and make sure that you get on the list. Oh, great. There's a sign-up sheet right out front if you want information on pop-up protests. Right, we'll put you somewhere. If you show up here at 1:30, then on the second Sunday of each month, and you haven't been able to sign up, just be here by 1:30 and we'll put you in a group. Thank you, Jan. Any other? Well, thank you so much for coming today. Thank you so much for your support of us and for all the people in America who are trying to save our democracy.
Thank you.
That's right. Silence is not an option.